Dr.
Oh,
Dan's account.
okay. All right. Yeah. So it's just me and my classmate Josh here.
Okay, cool. Well, let's get started. I am a bone radiologist, so I was going to talk to you guys about cervical spine imaging today because I think that's something important that you guys will see in the ER. You know, patients who come in with trauma, and certainly neck pain is a huge thing that you guys will see in your clinic as well. But mostly we're going to focus on trauma today.
Yeah, we're actually both going into ER. So that's
Oh, great. Well, that's perfect. I picked this just for you. So a little bit about myself. I actually went to UC Riverside back when they had the UC Riverside UCLA kind of combined 7-year med program. I don't know if you guys know about that. But that was the biomedical sciences program that kind of morphed into what is your medical school now. So I'm really familiar with, you know, your campus and just excited to be giving you guys a lecture and so excited that you guys have a med school there at Riverside. Okay, how do I go? Okay, sorry, this is the first time I'm doing this. So these are some learning objectives that we have for today. So first, who should have cervical spine imaging when we evaluate a patient coming in, how to decide who should be imaged, and then what modality to use to image them. Once we get those images, how do you interpret those C-spine radiographs, especially going in the ER? You don't want to have to wait for your radiologists to read everything. You know, a lot of times you can't find someone, and a lot of times it's just easier for the ED physicians to know how to read those. Once you have looked at the films, what are the common mechanisms of injury, just understanding how the cervical spine gets injured, and where are the common fracture patterns and locations to help you know specifically what to look for in a radiograph. And then finally, how do you decide if an injury is unstable or stable? So that's kind of what we're going to go over today. Cervical spine injury, as I was saying, is really common, and it's important because it affects young patients. These are 80% males. The most common age of presentation that we see is actually teenagers under the age of 20. Average age of these patients, when you look at all comers, is around 30, but still it's a population that's 15 to 40, and that's because these are patients who are motor vehicle accidents, fall, sports injury. So you can see that that demographic is a group of people who tends to be young and otherwise very healthy. Problem is that up to half of these injuries are associated with spinal cord injury, and that can be immediate, happening with the injury 85% of the time in these spinal cord injuries, or you can have 15% of spinal cord injuries that happen in a delayed fashion. These injuries can result in long-term debilitation and symptoms. So people coming in with post-traumatic neck pain, you know, being one of the most common things, but even as severe as long-term neurologic deficits, quadriplegia, and the costs are huge. People, you know, as I was saying, these are young, healthy patients who now are plugged into the healthcare system. And in a direct sense, they're hospitalized, they have immediate care, imaging, and then in a long-term sense, they have decreased quality of life, function, and possibly, you know, concrete things like lost wages or things that they can't do anymore. So when you see a patient come into the ED, clearly patients who have altered mental status or loss of consciousness should have cervical spine imaging. And these are all things that you're going to be evaluating, obviously, when you talk to them and examine them. If they have neck pain complaints, and that's just not just, you know, when they're not moving, but with motion. If you palpate their midline posteriorly and they have tenderness, that's another sign that should prompt you to get cervical spine imaging. If they have any neurologic deficits whatsoever, and then significant trauma at other sites. So any kind of mechanism that's bad enough to cause them to have a fracture in their leg or their arm might prompt them to be able to have cervical spine trauma as well. So we have the NEXUS criteria, which I'm sure you guys are familiar with. Oh. Hello?
Yes.
Wait, do you still see the PowerPoint?
No, we just see the main screen.
What happened to it? Mm. Okay, let me go out and start this over. Where did it go? Mm. Can you see it now?
It's on the right side of the screen.
Yeah, okay.
Yeah.
I don't know. I don't know what this green box is. My screen sharing is paused.
No, I mean.
Okay, well, okay. So we were on this NEXUS criteria. I'm just going to leave that over in the bottom right corner because I don't know what to do with it.
It looks really zoomed in.
What did you say?
The screen is really zoomed in from my end, at least. I don't know about Josh.
It's really zoomed in. Should I stop and start the share over? Let me try that. Do you see this now?
No.
Do you see the NEXUS criteria?
No.
Do you see it small?
No.
You see nothing?
I just see the main screen.
What main screen?
The main Zoom screen says join audio, share, invite others.
Invite others, share, join audio.
Yeah, like I don't see your computer screen at all.
Now do you see it?
Yeah, but it's really zoomed in. I don't know, Josh, do you see the same thing?
Is Josh there? Can you hear me?
Yeah, I can hear you.
Do you see anything right now? Hello?
I guess Josh sees the bottom part of the PowerPoint.
Okay, I don't know.
Yeah, me and Josh are seeing the same screen.
Okay, how about now?
Yeah, that's better. Yeah.
So it's just on the, is it just on the right side right now?
It's showing your entire screen, as in the entire PowerPoint screen with these slides on the left. So I think if you click start PowerPoint, it'll be fine.
Okay, so now is it back to the presenter view?
Yes, that's perfect.
Okay. Sorry, I don't know what happened. It just booted me out of that presentation. Okay. Anyway, so we're on the NEXUS criteria. So basically the NEXUS criteria is just a way to summarize what we were just talking about. So you have to have an absence of everything that we were just discussing. So no midline tenderness. They have intoxication as part of this because that plays into altered mental status. No focal neurologic deficit, and no painful distracting injury. Painful distracting injury being a significant fracture somewhere else in the body. So we always start with radiographs when we look at the cervical spine. And the standard 3 view that you get initially is AP, lateral, and odontoid. And in a perfect world, you would get the lateral view first and get your eyes on that and evaluate it before you keep going on. These films are supposed to be obtained with the cervical collar on, because you're not supposed to take that off until you establish that there's no unstable injury. So on the lateral view, it's paramount to see the cervical-thoracic junction. So you want to, can you see my arrow when I'm moving the mouse?
Yes.
Okay, so here's a lateral view here that's second over. And this one is C2, right? This is your C2 vertebral body. So the way you're going to know if you're getting down to C7 is you're going to start at C2 and go C3, 4, 5, 6, 7. So you want to see the cervical-thoracic junction, and that's because a lot of injury happens at that junction. If you don't see it, your choices are to repeat the lateral view, either in a swimmer's view position with the arm up, like over here on the right-hand side, or giving them some arm traction to try to pull the shoulders down. See, this soft tissue here that's overlying the cervical-thoracic junction is just soft tissue from the shoulders. So sometimes if you pull their arms down, it pulls the shoulders down as well and moves it out of the way. And then on your left, you have your odontoid view, and third over, you have this AP view. So these left three views are your usual routine cervical spine. Then if you have any questions on the cervical spine radiographs, you can move on to CT. So a lot of times in trauma patients, you can't clear the cervical thoracic junction, and you need to get a CT for that reason alone. And another thing CT is really good for is when you're looking at radiographs, you have a lot of superimposition of the bony structures, especially at the junction from the skull to C1 to C2. You have a lot of overlapping stuff there. And so sometimes if there's any question up there, they'll just do a limited CT scan of that top Atlantoaxial junction, or just scanning C7 to T1. And the beauty of CT is that if a fracture's subtle, occult, non-displaced, you don't see it on the radiographs, you'll pick it up on CT because you can reconstruct it in 3 planes. So you'll get axial, coronal, and sagittal planes. So what we're looking at here on the right is a reformatted CT scan in sagittal plane. Then you can go on to MR in certain select cases where you're worried about spinal cord injury, or if you're looking for more detail on the soft tissues. So MR is really good at looking at the ligaments, discs, the epidural space, the spinal cord, fluid around the spinal cord, and bone marrow edema. And then also it's useful to look at blood vessels if you have a fracture that you think may be involving the foramen, and you're looking for a blood vessel laceration or injury. So when you're looking at cervical spine radiographs, you can use this mnemonic AABCDS to evaluate the basic things about the cervical spine. So first, we already discussed that the radiograph has to be adequate. The lateral view has to include C7T1. Then the next thing you're going to look at is alignment. So these yellow lines here are the anterior and posterior vertebral lines. And what they're looking at is the anterior and posterior vertebral bodies. And they're joining the cortices along the anterior and posterior vertebral bodies. And you want them to be smooth and slightly lordotic with no step-offs. The turquoise line up at the top is showing you the front of foramen magnum, which is supposed to line up with the dens. This red line is the spinal laminar line, which is the basis of the spinous processes. And again, just smooth with no step-offs. And then the purple line is the posterior spinous line, which follows the tips of the spinous processes. Then if you go on to B, I didn't draw the outline of what your eyeball should do on these films because you should run your eyes around the cortices of all of the bones. So when you're first starting, sometimes it helps to use, an arrow or a cursor that you have on your packs to run around all of these vertebral bodies. And you want the vertebral bodies all to be similar shape, similar height, squared off, with no significant difference in the height at the front of the vertebral body and the back of the vertebral body. Sometimes you will have certain things that are related to anatomy, like the posterior vertebral body is allowed to be a few millimeters taller than the front of the vertebral body, or C4-5, sometimes you'll see that it's a little bit less height than the other vertebral bodies. And those things are just part of physiologic variation. So, but by and large, what you're looking for is a symmetry in all of these rectangular shaped vertebral bodies and no step-offs along the lines. Then you're going to look at, C stands for cartilaginous, which is sort of a reach because it's really referring to the predental space. That is at your space between C1 and the tip of C2. But they use cartilaginous to make it so you have a mnemonic that you can remember. If you look at this little anatomy drawing over here, you see that what's holding, this is sort of an axial plane, right? So you're looking down onto the tip of the odontoid process and then the ring of C1. And you remember from anatomy that you have this transverse ligament going behind the odontoid process that holds the odontoid process in a fixed space between the anterior arch of C1 and C2. In adults, that space should be 3 millimeters, and in kids, it should be 5 millimeters. And you're looking here on the radiograph at that space. So what you're looking for is that space definitely can get narrowed in cases of like osteoarthritis, but in a trauma case, you're looking for a widening of that space or change in that space with different positions. So sometimes you have lateral flexion and extension views, and I'm going to show you a case of that later on in this lecture. And you're looking for a change in the width of that space. Your discs are these intervertebral spaces. You want them to be pretty much similar from the front to the back and similar at all levels throughout. Of course, sometimes, like for example, down here in the lower cervical spine, we see that this is narrowed, and that's because this person has some degenerative disc disease. And you know that that's what it is because there's some spurring and associated findings that go on with degenerative disc disease. So that's something really common that you're going to see on these cervical spine radiographs. Then finally, to look at the soft tissues. So these are the prevertebral soft tissues we're talking about. We usually look at them anterior to C2, and the measurement that it's supposed to be is from C2 to C4, it should be less than 7 millimeter, and then from C5 to C7 in adults, less than 2 centimeters, and a little bit less in kids, 14 millimeters. So radiologists like to talk about this concept of the cervical spinal columns. And in order to understand that, I've put this anatomic drawing here on the top right. So this anterior longitudinal ligament kind of is analogous to what we were looking at before that parallels our anterior vertebral line. And then you have the posterior longitudinal ligament where we were looking at the posterior vertebral line. And in between those two, you have your vertebral body and your discs. Then posterior to that, you have your spinal canal. And on the sides, right, remember that your vertebral bodies are forming a ring shape coming back to the lamina and the spinous processes, and running in that spinal canal is your spinal cord. And so everything posterior to that posterior longitudinal ligament is the posterior column. And so this guy named Denis came up with these spinal columns, with the concept being that anytime you have involvement of two contiguous columns, that's defined as an unstable injury. Now, I want to call your attention to the fact that it's kind of not exactly intuitive. The posterior, or rather the anterior column does not include the full vertebral body, but only the anterior 2/3 and the anterior longitudinal ligament. The middle column includes kind of randomly the posterior third of the vertebral body and then just posterior longitudinal ligament. So the middle column is really small. Everything behind posterior longitudinal ligament, including the spinal canal, all the bony stuff that encircles the spinal canal, and then the spinous process, your interspinous ligaments, your neural arch, all of this stuff back here is part of the posterior column. So the posterior column gets way more than the anterior and middle column. They're not evenly divided. or even divided per se by anatomic distinction necessarily. And this Denis three-column concept applies to the lower cervical spine. Again, the columns aren't evenly spaced, and instability is involvement of two contiguous columns. Hello?
Did it kick you out again?
Yeah. Do you still see it?
No, but we can hear you.
Oh my gosh, this is so difficult. Okay. Do you see it now?
No. Now we're sounding like a Verizon commercial.
Seriously. Okay, how about now?
Yeah, you're good.
Okay. View, and let me go back to this.
Perfect.
Sorry, this is so choppy. I don't know if you guys are remembering anything I'm saying, but be that as it may, you still will get the multiple choice questions. I'm just kidding. Okay. Okay, so we were talking about this Denis three-column concept, and that was mainly applying to the lateral view, although you can, of course, use all your other imaging that you will have, CT and MR, to play into evaluating instability. So now we're going to look at this odontoid view, and I've put just a virgin radiograph on the left, and then I've drawn some lines on the right to show you what your eyeballs kind of should be tracing over. So the purple lines are the lateral masses of C1, and you can see with the blue lines that the lateral aspect of the lateral masses of C1 must line up with the lateral border of C2, the body of C2. And then you can see that the space between the lateral mass of C1 and the odontoid process, shown by the little horizontal yellow line, is supposed to be symmetric on both sides. When you go back to this radiograph on the left, you can see that that's symmetric on both sides. A little pitfall to be aware of is that sometimes when people are tilting their heads, that can cause one asymmetry in this space. But when it's due to position, it's going to cause widening of one side and then narrowing of the other side. So that's how you'll know that it's positional, as opposed to if you have a fracture or disruption of your C1 ring, you should have widening of both of them. Then you're going to run your eyes over the bones, the borders of the lateral masses, the cartilaginous spaces between C1 and C2, and then the cortex of the odontoid process. This white arrow is to remind you to look right here to see if there's any lucency extending down into the body of C2. On the AP view, we're going to look at alignment laterally. So these are our facet joints, and we're looking to see that the facet joints are lined up and that the lateral border of the cervical spine is lined up. Then you can run your eyes down the spinous processes. So we can see them here on the right, where the orange line isn't obscuring you. You can see the cortex of each spinal process en face, right? And then this green line is showing you to look at the height of the vertebral body on the AP view as well. Sometimes that can add some additional information looking at it on the AP view. And you can also evaluate the discs on the AP view in the same way. So this is the same patient we looked at his lateral view earlier, so you can see that in the lower cervical spine, the lucency that should be the disc height is narrowed. As we saw, he had degenerative disc disease on that lateral view. So let's move on to talk about some common mechanisms of injury. These are the three most common mechanisms that we talk about: flexion, extension, and axial loading or axial compression. And I'm going to go through some examples of these injury patterns so you can see. But just to remind you before we go into the radiographs that when you look at x-rays, you're only looking at the bones. And there are a lot of soft tissues and ligaments in the cervical spine that lend stability to all three columns. And so that sometimes you have to infer soft tissue injury by things like widening of the spinous processes back here that are normally held in tight position by the interspinous ligament. And when you tear this or tear the ligamentum flavum, you can have splaying of these, but you're not going to see that on a radiograph. So here's an example of a flexion injury that's a pure soft tissue injury, and this is an anterolisthesis. So what we're looking at is, on the left, we have a lateral radiograph where the person is flexed, and then on the right, we have a lateral radiograph where the person is in extension. Now, you're not going to get films like this in flexion and extension until you've cleared the cervical spine as no unstable injuries. And then when you get flexion and extension views, you don't move the patient's neck for them. You have them voluntarily flex and extend just within whatever range of motion they can handle. So if you see at C3, if you follow your posterior vertebral line, there's a little step off here from C3 to C4 that we do not have on extension. It's only on flexion. And so in a person who's coming in with trauma, that has to be assumed to be a soft tissue injury until proven otherwise. Now, we can see anterolisthesis with associated fractures, sometimes with muscle spasm, and occasionally you can get very mild anterolisthesis in young patients who just have very flexible necks. But be that as it may, this is what you're looking for on these flexion and extension views. And certainly if you see this kind of cortical step off on a not flexion extension view, you want to be aware that there may be some underlying soft tissue injury there that's allowing disruption of those vertebral lines. Hello?
Yeah, we can hear you, but it exited the screen again.
I know. Okay, here's a flexion teardrop fracture, and this is a fracture pattern that happens because you have flexion loading, and you can see this oblique fracture line and this fracture fragment, right? So basically, the front of this vertebral body gets hit up against the vertebral body below, and you get this oblique fracture line and displacement of the vertebral fragment anteriorly. And so you have disruption of usually both the anterior and posterior vertebral lines due to soft tissue injury, as you can see in this line diagram over here. On this example, we don't see very well disruption of the posterior vertebral line, but you do see widening of this interspinous, where the interspinous ligaments would be, and you see a very difficult to visualize non-displaced spinous process fracture right here. Can you see that? Hello?
Kind of.
Kind of, okay. Another thing I want to point out to you on this lateral view is, see how, so these are your facet joints, these lucencies from level to level, and see how you can see this double facet line?
Yeah.
You're not really supposed to see that. I see that from this level on down, but not at this level and this level. So what these double facet lines are telling me is that this patient is a little bit malpositioned and obliqued. So again, a way to evaluate whether this film is adequate or not. So that was a flexion teardrop fracture. Again, disruption of the anterior and posterior soft tissue structures, leading to this fracture being an unstable fracture because you can have compression of the spinal cord due to movement of the vertebral column. So the radiographic features that you're expecting to see are prevertebral soft tissue swelling, the teardrop fracture that we saw usually from the anterior and inferior vertebral body. The posterior vertebral body is often posteriorly displaced into the spinal canal and can compress the spinal cord due to displacement of that whole vertebral column. And then, as seen on our case, you may see a spinous process fracture and interspinous widening, and this is indicating to you that there's ligamentous injury. Here's another example. Oh, sorry, not another example of that. An example of an extension injury. So here's a normal film on the left for comparison. And what I want to draw your eyes to is look at behind C2 as I go into my pedicles and my spinous process. Look how smooth this cortex is. In contrast, in this abnormal film, I see a step off right here. Instead of having my cortex go like this, I go here, and then there's a little jog right there and a lucency going through there. My prevertebral soft tissues are way too thick anterior to C2. Remember, this was supposed to be 5, right? And then I have disruption of my anterior vertebral line. C2 is forward of C3. So this is a very common fracture, which is a Hangman's fracture. And these are bilateral fractures through the C2 pars interarticularis. The pars interarticularis is the part of the C2 that is going from the body into the superior and inferior articular masses. And the mechanism of this was called a Hangman's fracture because back in the day it was hanging as the rope would snap the person's neck up into hyperextension. But now we see this in motor vehicle accidents. And also occasionally you can get this kind of fracture from flexion, but much less commonly. So again, you're going to see prevertebral soft tissue swelling, disruption of your pars, and anterior dislocation of that C2 vertebral body from disruption of your anterior longitudinal ligament. This fracture is unstable, but usually doesn't compress the spinal cord because of the bilaterality of it. Since you have bilateral fractures, that ring tends to distract, meaning the front portion of the C2 moves anteriorly and the back portion of the C2 moves posteriorly so that you don't have squeezing on the spinal cord. Okay. You guys can look at this one. Do you see anything here? This is a lateral reconstruction of a CT of the cervical spine. Different fracture from what we've looked at before. We're looking in the lower cervical spine.
There's a step off, I think, at C6.
Yeah, exactly. In the spinous process here at C6, we have a step off. So here to here, we have a lucency going through. And this is a funny named fracture called a clay shoveler's fracture. It was first described back in Australian clay shovelers who would dig up clay in the ground and then throw it over their shoulders into a pile. And because of the stickiness of the clay on their shovel, as they would throw it over their shoulder, the heaviness and the weight of the clay would pull their cervical spines and their shoulders back into hyperextension, and they would get a sudden muscle contraction, which would cause avulsion of that spinous process. And so this is classically a fracture we see at C6 or C7, usually oriented obliquely between the spinous tip and the lamina. Oftentimes there is displacement and distraction of the fracture fragment because it is an avulsive injury, but it's stable because it involves, again, only the posterior column. We're going to move on to discuss axial loading injuries. These are common injuries resulting from things like direct head injuries. So these are patients who are jumping on a trampoline and land directly on their head, diving into shallow water, and their head hits the bottom of the pool, or wherever they're diving into, or any kind of something heavy falls on top of a person's head, or they hit their head on the top of a flipping car during a motor vehicle accident. All of these are mechanisms that cause axial loading. And so you can see on this radiograph, the red arrow is pointing to lucencies in the posterior ring of C1. And so this person went to CT scan, and you can see the odontoid process. And not only are there posterior ring fractures, but also fractures bilaterally, anteriorly at C1. And you can see some comminution here as well. And so if you imagine what this odontoid radiograph would look like, and we're going to look at some examples, but just you can see really nicely on this axial view how the normal space from the odontoid process to the lateral mass of C1 is asymmetric here. This is that space that you're looking at on that apiodontoid view. Normally your apiodontoid view is looking this way, right? So you're seeing this space compared to this space on your odontoid radiographs. Here's an example where, well, my lines moved a little bit, but I'm trying to show that on the lateral view, it can be very difficult sometimes to see these C1 fractures because you have superimposition of the base of the skull, you have superimposition of the C2 process overlying the ring of C1. And that's why these odontoid films are very, very helpful. You want to make sure for the adequacy of these films that the person's mouth is all the way open so that you can see the relation of the lateral masses to C2. And if their mouth is too closed, then you may need to repeat them, because if you have the teeth overlying this, then you're not going to see the step off of C1 to C2. See, what we're looking at here is that this outside cortex should be lined up. This lateral mass of C1 cortex should be lined up with the cortex of C2, but no, it's all the way over here. And you can also see this widening of this space from the odontoid process to the lateral mass. So we're looking at this and this way too wide, and then this step off here, which is an abnormal offset. Same patient CT scan, and you can basically see the same exact thing that you could see radiographically. So you could have made all these findings on the radiograph already, which is the widening of the space from the lateral mass of C1 to the odontoid process, the step off here at the cortex of C1, C2, and then the axial view of the cervical spine really nicely shows us this ring fracture of C1. And so this is a named fracture called the Jefferson fracture. And basically it's a burst fracture of the C1 ring. What you have is crunching of that C1, and it tends to just shatter and pull apart. The occipital condyles basically catch the lateral masses between the occipital condyles and the body of C2 and squeeze on that C1 ring. And these radiographic features are exactly what we just looked at. The lateral displacement of the C1 masses, fracture lines in the anterior and posterior arches that we can see on the CT scan. Sometimes you may have an associated C2 fracture, as you can imagine. On the lateral view, you might have an increased atlantodental interval if you have disruption of the transverse ligament. So that was going back to that Gray's Anatomy drawing that I showed you with the transverse ligament going behind the C2 process there. And these fractures can be stable or unstable, just depending on their fracture pattern and definitely on whether they have involvement of C2. And we're going to talk more about C2 odontoid fractures in a little bit. Here's another example of axial compression. And so what you have is this comminuted vertebral fracture through the body of C7. And what you see is that the anteroposterior dimension of the C7 vertebral body is increased. So it's like fatter from front to back than the normal vertebral body here. And that's because your axial loading came this way. So you have a force coming down on that vertebral body, which causes the fracture fragments to pull posteriorly and anteriorly. And you have a lot of prevertebral soft tissue swelling here, anterior to C7. So this is just the same mechanism basically as that C1 Jefferson fracture, just lower down in the vertebral body. And you have axial compression that pushes the disc into the vertebral body and pushes those fragments apart. On the radiographs, you're going to see loss of vertebral body height and spread anterior to posterior. The posterior cortex is almost always going to be involved in that fracture. And then you're going to have posterior retropulsion of the vertebral body. And this is the problem with these fractures, is that that posterior retropulsion can push on the spinal canal and the spinal cord. So in those cases where you have retropulsion, these fractures can be unstable, and they need an MR to evaluate whether there's edema in the spinal cord or spinal cord compression. Not again. Where's my arrow? Oh my God. Okay, I'm getting really good at this restarting thing.
Josh wants to know if burst fractures are a general term for fractures resulting from axial loading.
Burst fractures mean that, no, axial loading is the mechanism and the burst fracture is the pattern. So when I say burst fracture, I mean that if you were to look at it, it looks exploded and it has movement of the fracture fragments anteriorly and posterior. That's what I mean by the burst of it. But when I say axial loading, that is the mechanism of how that fracture happens. But axial loading can result in other fractures as well, not just burst fractures, although burst fractures result from axial loading. Is that clear?
Yes,
meaning that axial compression can result in burst fractures and other injuries. But when you see a burst fracture, you know that at least there has been some component of axial loading. But for example, you could have a cervical spine injury that's axial loading plus some hyperflexion. So that may or may not be a pure burst fracture. One term is discussing the mechanism of where the force came from. The other term, the term axial loading versus flexion versus extension, is the way that we describe the person's position of their neck and the way the force came on the cervical spine during the injury. When we say burst fracture, that is a description of what we see radiographically in the vertebral body after the injury. Is that clear? Hello? Hello?
He says it's clear.
Did you guys hang up on me because it wasn't clear?
No. He says it's clear.
How come I can only hear you and no one else?
Oh, because his mic doesn't work.
Oh.
But he's sending messages.
Oh, really?
If you go to the messages, you can probably see his messages.
I'm afraid to do anything else.
Yeah, it's okay. I
see these chats.
Yeah, I can be the communicator.
I see the screen that says, oh, okay. Yes, I understand. Thank you. Yeah, sorry. Okay, I see it. Okay, thanks, Josh. Now how do I make this go away, though? Okay, there. All right, so we're talking about now some other cervical spine injuries that don't necessarily have such well-defined mechanisms, but are still important fracture patterns to understand. And so first, I think the bulk of the rest of this lecture, we're going to talk about some different types of odontoid fractures. So I'm going to show you 3 cases of odontoid fractures right now, and then discuss with you the classifications of them. So on the left here, we have this lateral radiograph. And what I'm showing with these blue lines is this is the posterior cortex of C3. And this is the anterior cortex of C2. And this is way forward of my anterior C3. And this posterior C2 cortex is way forward of my posterior C3 cortex. I didn't draw a line here because when I drew the line, it was like really hard to see this cortex because this person's kind of osteopenic. So this arrow is supposed to be indicating this, posterior vertebral body. So you can see a major anterolisthesis of C2 on C3. And this triangular thing back here is the fracture fragment that is the bottom of C2, which when we come over on the C2, on the CT, we see that much better. This triangular fracture fragment is this triangular fracture fragment. And this shifted forward remainder of C2 is this shifted forward remainder of C2. So you can see that this fracture line is oblique. It's going down to the articular surface. And when we look at it on the axial CT scan, it's in the body of C2 and coming all the way down to the inferior aspect of C2. This is a very hard to see fracture. If you start with the odontoid view, you can see that something's not quite right. You see this asymmetry between the lateral masses of C1 and the tip, right? This is a little wider than this. And then on this lateral view of the cervical spine, what I'm pointing to you is there's a triangular fragment here that's articulating with this C1 arch. And this triangular fragment is the tip of the odontoid. And this red line is pointing to this lucency. So I'm coming up my back of C2 right here. And then basically I lose the cortex. Where is the cortex that should continue from here up around as we usually see on our odontoid, right? I don't see that. So we go to CT, and again, here's my normal back of C2, and I'm coming up, and then I lose that back. And that's because it's over here. I lost my arrow. It's over here. We have a fracture line, and the back of C2 is displaced forwardly. On the odontoid view, or on the coronal CT here, you can see that you have the fracture line extending down into the C2 vertebral body. Similar to that other fracture that we looked at, but not quite as inferior. And then finally, we have a fracture here, where on our lateral view, we can see a well-defined lucency going through the base of C2. And in fact, there's sclerosis on either side of the fracture line. And again, on CT scan, we see the same thing. Fracture line here, but sclerosis. What does that mean to you? That sclerosis.
Osteoarthritis?
Well, that's a good idea, but there's not a joint space here. And so when you see sclerosis where you're thinking there could be a fracture line, you have to think about a few things. One would be, well, is this some kind of anatomic variant, like an accessory ossicle that is a pitfall for me to think that this is a fracture? There is such a thing. It's called the os odontoideum, which is an accessory ossicle, and it doesn't fuse with the body of the odontoid. In that case, usually it looks more like a small little round bone, not so perfectly shaped like the odontoid process. In this case, basically, this looks like a normal shaped dens, C2, right? Except for that there's just this lucency through. And then I see the sclerosis. This tells us that this fracture is old. Because a normal fracture, when we go back, let's just compare that. Look at this fracture line here. Look at this fracture line here. Look at this fracture line here. It doesn't have any white margin here and here, right? This stuff is the cortex, but along the margin of my fracture fragment, I shouldn't see that kind of sclerosis that I'm seeing here. So this tells me that this is an old fracture that didn't heal. And the sclerosis and subchondral cyst formation is here because these two fracture fragments have been rubbing against each other chronically. So let's talk about what all that was. Odontoid fractures are very common cervical spine fractures. kind of a mixed mechanism, so that's why I didn't put them under specifically flexion, because it can be flexion, but it can be extension. And here are some classifications for odontoid fractures. The most important fracture pattern and the most common one is the ones that we were looking at. And so those are type 2 and 3 fractures. Type 1 fracture is really uncommon, and it's an avulsion fracture at the tip of the odontoid process. And it's a little small fracture fragment, so it's hard to see, and you probably wouldn't see it unless you had a CT anyway. And it's a rare avulsion fracture, and you just put those people in a collar. Type 2 fracture is like the fracture we just looked at, where it's through the base of the dens. It doesn't go into the body of C2. This is the most common fracture pattern, and the problem with it is that more than 50% of these cases result in non-union, which was what we just looked at, meaning that those fractures don't heal in greater than 50% of the time. And so that's why if you put them in a halo and they're not improving, some of these patients will go to surgery because the risk of non-union is so high. The type 3 fracture was the other fracture that we looked at, where we had that kind of curvilinear fracture line extending down into the vertebral body. And that's also either a halo or surgery, and less common than the type 2 fracture. So here are some pitfalls when you're looking at odontoid fractures. Again, the os odontoideum, which is either an incompletely fused dens, it can be hypoplastic, or the top of the dens can be just absent. Some people just don't have the top of the dens or have a very small one. Another kind of pitfall is called the MAC line. So because you're obtaining these views from front to back with the person's mouth open, a lot of times what you'll get is overlying soft tissue structures or other structures projecting over C2, like teeth or other bands like from their head. And so here the red line is showing you what we call a MAC band or a MAC line. And you could mistake this for a fracture, but the key to knowing that it's not is see how it continues past the bone, right? Like here's the line, but I see it going over here and I see it going over here. So I know that that's not confined to the bone, so therefore it can't be a fracture. So that's a MAC line. And then finally, an Atlantoaxial dissociation. This is looking at the atlantodental interval in flexion and extension. So on the left, you can see that the person's chin is down and their spine's curved forward, so that's a flexion radiograph. On the right, that's an extension radiograph. And you can see how much movement there is in that space from C1 to C2, from flexion to extension. And so that lets us know that there's disruption of our transverse ligament and there's dissociation. Now the axis and atlas are not moving as one unit anymore. So in conclusion, we've talked about who should have cervical spine imaging. We talked about how to evaluate patients, what you want to look at in their clinical history and on their physical exam, and using the NEXUS criteria to clear the cervical spine. What modality should you use, starting with radiographs, looking at that lateral radiograph, keeping them in their soft collar, and then if you have questions, using the CT scan. Remember that lateral radiographs will pick up the majority of cervical spine fractures, 85 to 90%, and so that most patients don't need a CT scan, but we will use it sometimes for inadequate films, such as when we're not seeing C7 T1. And then using MRI to look at soft tissues and the spinal cord when we suspect ligamentous or spinal cord injury. How you interpret cervical spine radiographs, I gave you the mnemonic of AABCDS and applying that on radiographs. And then we discussed a couple examples of flexion and extension lateral views and how you can evaluate those. Common mechanisms of injury, so flexion, extension, axial loading, and then other, meaning mixed, where you can't really kind of distill it down to one, isolated mechanism of injury. We looked at some common fracture patterns and locations, like anterolisthesis, teardrop fractures, Hangman fractures of C2, Jefferson fracture, which is just the named burst fracture of C1. I showed you an example of another burst fracture, and then we talked about odontoid fractures and their classifications. And then we discussed stability and the column theory of cervical spine stability and the 3-column model that we can use. And then, finally, obviously, if we evaluate a cervical spine injury and it's unstable, that we need to often use further workup like CT or MRI to evaluate associated injuries to soft tissue, things like the vertebral arteries or the spinal cord or ligamentous injuries that can result in people having long-term neck pain, even if we don't see a specific bony fracture. So that's it. Oh, look at Josh F. He was right. Chronic fracture. I see the chat now. Okay. Does anybody have what? He's showing off now?
Yeah.
Okay, well, thank you so much. Thank you. What's your name? Speaker of the House?
Gerardo.
Okay, well, thanks for being the one sole person who had to answer all my questions. Sorry, you guys, about all this crashing of my PowerPoint. I actually just got a new computer, so this is like the last thing I'm doing on this one. And thanks, Josh. And next time it'll be smoother. But anyhow, good luck to you guys, and I hope you know how to read a C-spine film now.
Thank you.
You're welcome. Oh, do I give multiple choice questions to you guys or to the clerkship director?
I think to her. Yeah.
Okay, I'll give them to Dr. Tan. Okay. Thanks, guys, and have a good day.
You too. Bye-bye.
Okay, bye-bye.